Assalamu alaikum everyone. In this lecture, we'll be talking about the innervation of gastrointestinal tract. By the end of this lecture, you'll be able to identify what is the enteric nervous system or intrinsic innervation, enteric nervous system, and what is the extrinsic innervation, including the sympathetic and the parasympathetic innervation to the gastrointestinal tract, and what are the functions that are carried out by each system. Let's first begin to talk about the extrinsic innervation, particularly the sympathetic nervous system. Okay, so let us revise together the parts of the gastrointestinal tract. Okay, so as we already know that the abdominal part of the esophagus, the stomach, and about halfway through the duodenum, just below the major duodenal papilla, proximal to that, we call that foregut, right? This is the foregut. And then down below, including the jejunum, the distal part of the duodenum, and the jejunum, and the ileum, and also down below the cecum, appendix, and the ascending colon, right? And approximately 2/3 of the way along the transverse colon is called midgut. Then distal to that until the rectum, right, is the hindgut. Is that right? Okay, so let us speak about one point. After we've revised the parts, foregut, midgut, and hindgut, I want to talk to you about the sympathetic chain, the general anatomy of the sympathetic chain, okay? So, the general scheme, we've already talked about them in previous lectures, but the general scheme is that we have that spinal cord, right? A section in the spinal cord, and the basic structure of spinal cord internal anatomy, that it has 2 dorsal horns and 2 ventral horns. This is the gray matter inside, and the rest is white matter, right? So that's the gray matter of the spinal cord, which contain neuronal cell bodies, and outside here is the white matter of the spinal cord, which contain ascending and descending tracts. That's the basic anatomy. But when you take a cross section in the spinal cord anywhere from T1 down to L2, from T1 level to L2 level, you will see one additional structure, which is a horn over here, right? This is called the intermediolateral horn, or simply lateral horn. This structure is called what? Intermediolateral horn, or simply lateral horn. This structure, you will not see it in other sections of the spinal cord above T1 or below L2. This is only present between T1 and L2. What is this structure? This structure in fact contains the cell bodies of the sympathetic preganglionic neuron. The cell bodies of the sympathetic preganglionic neuron. So for purposes of explanation, I will just draw this horn as one neuron, which is the preganglionic sympathetic neuron. Okay? I will give it this color. This is the preganglionic neuron, the cell body of which. Okay? Now, also, we know that the spinal cord give rise to spinal nerves, right? So we'll just talk on this side of the screen. We know that the sensory input from the body is coming in through the dorsal roots, which connect here, right? Whereas the motor emerge from the anterior horn, right? So we have ventral root, which contains motor neurons, right? Those are motor, supply skeletal muscles. And we have dorsal root, which is sensory. Is that right? That's sensory, purely sensory. Now the motor root and the sensory roots, they come together and form spinal nerve, right? They mix together and form a spinal nerve. Of course, there are multiple sensory roots and there are multiple motor roots. It's just not one, right? They mix together in this structure, which is the spinal nerve, right? This structure, which is the spinal nerve over here, that's spinal nerve. Now, the thing is that the spinal nerve, after it emerges from the intervertebral foramen, it will split into two rami. You have to know, it's very important to know the difference. A small dorsal ramus and a much, much bigger ventral ramus or anterior ramus. Now, those sensory and motor fibers which will supply the back, generally intrinsic back muscles. When I say intrinsic back muscles, means muscles which have embryologically originated in the back and stayed in the back, right? Those are called intrinsic back muscles. Along the skin on the back in the midline are supplied by the dorsal ramus. Dorsal ramus. So those sensory fibers which supply the back and the midline will pass here, and those motor fibers which will supply the intrinsic back muscles pass here in the dorsal or posterior ramus, not root. Be careful about this point. Whereas everything else in the body, like muscles in the upper limb, in the lower limb, etc., they receive their input through the ventral ramus, both motor and sensory. So what is the bottom line here? The bottom line is that roots are pure. When you talk about roots, when you say dorsal root, you mean pure sensory fibers. When you talk about ventral root, you mean pure motor fibers. Okay? But when you talk about rami, they are mixed. The dorsal and ventral rami have mixed motor and sensory fibers. Okay? So after we talked about this general scheme, how the sympathetic nervous system fits in. So this is our beautiful ganglion, or sorry, it should not be called a ganglion. The cell body of the preganglionic sympathetic neuron sits here in the intermediolateral horn. Now, its axon will leave with the ventral roots and enter into the spinal nerve, right? It's now inside of the spinal nerve. The thing is that this axon is myelinated. Okay, this axon of the preganglionic neuron, it is what? It is myelinated, means it contains a myelin sheath and it is moderately myelinated. So it is type B fiber. It's, the classification of nerve fibers according to, we talked that in physiology, type A, type B, type C, and the subtypes. Well, this one is type B, okay? Type B means moderately myelinated nerve fiber. Okay, this myelinated, of course, myelin appears white. It's white. This myelinated nerve fiber leave the spinal nerve and generally speaking will synapse in a ganglia outside with the post-ganglionic neuron. I'm going to give it this color. Okay, post-ganglionic neuron. Now, the post-ganglionic neuron will leave the ganglia and generally speaking will come back to the spinal nerve to be distributed to peripheral targets with the spinal nerve. So the ganglia is receiving a preganglionic fiber and giving rise to a postganglionic fiber, right? And this postganglionic fiber re-enters the spinal nerve to become distributed with the periphery. Is that right? So, when we talk about the myelination of the postganglionic neuron, it is unmyelinated. It is unmyelinated, okay? Has no myelin sheath, unmyelinated. And it is type C fiber, type C, okay? Because the preganglionic neuron is myelinated, we call it white ramus communicantis. White. We talked about it previously, we're just revisiting the basics. White ramus communicantis. And the unmyelinated fiber, right, we call it gray ramus. Gray ramus communicantis. Okay? Okay. So, gray ramus communicantis is unmyelinated, it's type C, it is post-ganglionic. It emerges from the ganglia, re-enters the spinal nerve to be distributed peripherally. The preganglionic fiber, after it emerges from the spinal nerve, we call it white ramus. It's myelinated, it's type B, it enters the ganglia and synapses with a postganglionic neuron inside the ganglia. This is the general rule, but there are exceptions. There are exceptions to this rule. Now, what are those exceptions? If we take across, a diagram, different diagram, this is our spinal cord starting at T1. Suppose that's spinal cord starting at T1. It have this intermediolateral horn and to the end, okay? That's the end of our spinal cord, suppose. And of course, there are multiple segments in the spinal cord. The ganglia that I told you about, the sympathetic ganglia, are generally arranged in a chain-like structure. So that's a ganglia, that's another one, that's another one, on either side of the vertebral column. Okay? On either side of the vertebral column. These ganglia, the general location, they are connected with each other like this. Okay? They're connected with each other. These ganglia in the neck, they are behind the carotid sheath, posterior to the carotid sheath. In the thorax, they are anterior to the necks of the reps, in the upper thorax. In the lower thorax, they are immediately lateral to the thoracic vertebrae. And in the lumbar region, they are anterolateral to the lumbar spine. And then in the sacral region, they are anterior to the sacrum, medial to the sacral foramina. And then they meet each other in front of the coccyx to form the ganglion impar. So what do I mean by that? I mean that these ganglia, the chains, they move superiorly, they are lateral, but as they descend, they are moving more and more medially. You get me? They are moving more and more medially, such as that in the end, in front of the coccyx, they meet at one ganglion called ganglion impar. Ganglion impar. So here in the neck region, they are posterior to carotid sheath. In the upper thoracic, right, they are in front of the necks of the ribs. Those are ribs. In the lower thorax, they are just lateral to the vertebrae bodies. Lower thorax. And in the lumbar region, they are anterolateral to the vertebrae. They are on either side, anterolateral to the vertebrae. And when you enter the pelvis sacrum, these are the sacral foramina. They are medial to the sacral foramina and anterior to the sacrum. This is the general location of this chain. Okay, now let's speak about the general rule that we talked about is that this is the spinal nerve emerging out, right? And the nerve, the preganglionic nerve, move interganglia and synapse with postganglionic nerve. Postganglionic nerve come back to the spinal nerve, right? That's the general rule. Exceptions exist. Sometimes the preganglionic neuron, axon, it just enters the sympathetic chain but does not synapse at the ganglion of the same level. It may move down or may move up to synapse at the correct level, and then the postganglionic nerve emerge from that. Example is that at T1 level, you know, in the cervical region, there are 3 ganglia: superior, middle, inferior cervical ganglia. At T1 level, the preganglionic nerve fiber enters T1 ganglia but does not synapse in it. It actually moves up to reach the superior cervical ganglion and synapse with a postganglionic neuron, and then that goes to the oculosympathetic pathway. That's a different story. In head and neck we talked about it. So one example is that yes, it enters the chain, it synapses in the chain but not in the same level as the chain. The second method or variation is that sometimes the preganglionic fiber passes through the chain without synapsing at all and go to a different ganglion or target. So how sympathetic nerve fibers leave? The commonest general rule is that they leave, enter the sympathetic ganglion at the same level and synapse there. The second method, they enter, do not synapse in the same level, move up or down to find the correct ganglion and synapse. The third method, they just leave without synapsing. Okay? All right. So let's talk about those sympathetic nerves that supply the abdominal organs. Let's first begin with those that supply the foregut. Foregut. Okay. So, which one supplies foregut? So, let's draw a spinal cord here, okay? That's spinal cord sections. Starting from T5, okay? That's T5. 6, 7, 8, 9, 10. Of course, that's 11 and 12, okay? The preganglionic sympathetic nerve fibers emerge from T5. Those the ones that emerge from T5, 6, 7, 8, 9, and sometimes 10. They come together. These nerve fibers, they come together, okay? And they just skip the sympathetic chain, okay? They do not synapse in the sympathetic chain. So they will just skip the sympathetic chain without synapsing at all. They are preganglionic. They come together and form one big nerve, okay? This nerve is called greater splanchnic nerve. Greater splanchnic nerve. Now, this nerve, again, it's coming from T5 to T9 and sometimes T10 is included, and it is all preganglionic. They love to ask about this in the exam, okay? It is all preganglionic. It does not synapse at all in the sympathetic chain. Of course, this nerve originates inside of the thorax. Then where does it go down below? It is so simple. Let's move down here. Okay, this is, I will draw the diaphragm and the aorta. Okay, so here is the aorta, abdominal aorta as it enters through the diaphragm. Here's the celiac trunk. Superior mesenteric artery is over here, just under the celiac trunk. And of course, here's inferior mesenteric artery. Of course, as you already know from thorax, that aorta enters behind the median aricoid ligament, right? I'm gonna give it this color. Yes. This is median aricoid ligament, which is formed when the right cross of diaphragm and the left cross of the diaphragm join together. Is that right? Already talked about that, guys. Then, the greater splanchnic nerve, as it is coming down from the thorax, it just simply pierces the crura of the diaphragm. Okay? They pass through the crura of the diaphragm on either side of the aorta and enter the abdomen. In the abdomen, these preganglionic nerve fibers, they synapse at a ganglion, which is over here. Okay? That's called celiac ganglion. Celiac ganglion. Here they find the postganglionic neuron. So they synapse here at the celiac ganglion with a postganglionic fiber. The postganglionic fiber emerge out, right? And they pass these fibers, these filaments, they pass along with the branches of the celiac artery, right? To supply spleen, stomach, liver, and gallbladder, right? Those four gut structures, guys, and pancreas. But also importantly, some of these fibers go where? Some of these fibers from the greater splanchnic nerve originally, they supply the adrenal medulla. But those, they don't synapse. They just pass from the greater splanchnic nerve directly without synapsing in the ganglia. Okay? Those are preganglionic sympathetic from the greater splanchnic nerve that supply the medulla, meaning that here they release acetylcholine, right? They don't release adrenaline, because we know noradrenaline. We know that generally speaking, all preganglionic autonomic nerve fibers are cholinergic. They release acetylcholine. And almost all postganglionic sympathetic fibers, they release noradrenaline, meaning they are adrenergic. The parasympathetic system is entirely cholinergic, pre and posts. Okay? This is a common question in the exam, very, very common. What is the innervation of the adrenal medulla? Preganglionic sympathetic nerve fibers that are coming in from the greater splanchnic nerve and release acetylcholine at the adrenal medulla. Some people think that the adrenal medulla is a modified ganglion, modified sympathetic ganglion. But anyway, so that's four guts supplied by greater splanchnic. What about the midguts? The midgut is supplied by nerve fibers which originally come from T10, with contribution from T11 in some cases or T9 in some other cases. Okay, so it is T10 plus minus 1, right? It's T10 and T11, or T10 and T9. These preganglionic nerve fibers come together and also do not synapse in the sympathetic chain and form a nerve which is called lesser splanchnic. This is called lesser. Splanchnic means, it's a Greek word, splanchnic. Lesser splanchnic nerve. Splanchnic is a Greek word which means viscera. So any nerve you come across that is called splanchnic nerve, it means it's a nerve that supplies some kind of viscera. This lesser splanchnic nerve also pierces the crura of the diaphragm and come to the abdomen. The lesser splanchnic nerve synapse at possibly two ganglia, okay? You know that's renal artery from the aorta, right? That's renal artery over here. There's a ganglion between the renal artery and the aorta called aorticorenal ganglion. There's a ganglion over here. This ganglion is called what, guys? Aorticorenal ganglion. Okay? Now our friend here, the lesser splanchnic nerve, it synapses here at the aorticorenal ganglion, or sometimes it synapses at a ganglion over here called superior mesenteric ganglion, associated with the superior mesenteric artery. It's variable, okay? It may come here, it may come here. The post-ganglionic nerve fibers, they are distributed along with the branches of the superior mesenteric artery to supply midgut structures. That is, it's going to supply the jejunum, the ileum, the cecum, the appendix, the ascending colon, and the proximal 2/3 of the transverse colon, right? With fibers. Okay, then we have another nerve which comes from T12. That's a nerve which is coming from T12. I'm gonna give it a different color so that we don't get confused. This nerve comes from T12, preganglionic. Also don't synapse in the sympathetic chain, and it is called the least splanchnic. Least splanchnic. Least splanchnic enter abdomen with the lesser and the greater splanchnic nerves, and it simply moves to the plexus around the kidney, that's renal artery, and this is ureter, right? It synapses in the renal plexus, right? It synapses at a ganglia in the renal plexus and supplies kidney and supplies ureter. Okay? This is called least splanchnic. Together, greater, lesser, and leasts. So let's summarize. We have three nerves: greater, splanchnic nerve, lesser splanchnic nerve, least splanchnic nerve. They are all called thoracic splanchnic nerves. Thoracic splanchnic nerves, because they come from the thoracic spine, right? So, greater splanchnic nerve supplies foregut. Lesser plus they supply also adrenal medulla. Lesser splanchnic nerve supply midgut, and least splanchnic nerve supply renal plexus. Okay? Together, what's common in them? All of them are preganglionic. All of them are preganglionic. All of them don't synapse in the sympathetic chain. They just pass through it without synapsing. They have different targets, ganglia, right? The greater is the celiac ganglion, the lesser aorticorenal or superior mesenteric ganglion, and the least it synapses in the renal plexus. What are the functions of these nerves? So simply they give two kinds of functions. Function number one, they are providing visceral efferent fibers, that is motor fibers, visceral efferent fibers, to those structures that we spoke about. So, for example, they will reduce the motility in the gastrointestinal tract in the foregut and midgut. They reduce secretions, and they cause splanchnic vasoconstriction. The blood vessels supplying these structures undergo constriction, thus raising the blood pressure because it diverts the blood away to more vital organs. They reduce the renal blood flow because, especially we talk about the least, it reduces renal blood flow, and therefore it is also a part of the stress response, right? And releases adrenaline and noradrenaline from the adrenal medulla via the greater splanchnic. The second function, they also contain afferent fibers. Now listen, that's very important point. When I talk about autonomic afferents, that is sensory fibers that belong to the autonomic nervous system, they are of two types, right? Two types. When you talk about autonomic afferents, they are of two types. Those types that takes in visceral pain, and some other type takes in physiological information, like the luminal pressures, like in the heart, the cardiac chamber pressure, or the baroreceptors, or the chemoreceptors. Things about the physiological processes in the body. Those type of fibers which take physiological information are parasympathetic. They are parasympathetic afferents. But those that take in visceral pain are sympathetic. So what is the function of sympathetic afferents? Visceral pain. It means that greater, lesser, and least do not only contain motor fibers, they also contain sensory fibers from the same structures. Now here's the important trick. When you focus, that's common in exam, when you focus on T10, right? When you focus on T10 level, which is the main root for the lesser splanchnic, right? Lesser splanchnic, main root for lesser splanchnic. And I've already agreed with you that lesser splanchnic nerve supplies midgut structures, okay? Including the appendix, So if there's appendicitis, inflammation in the appendix, the pain is carried by visceral afferents via the lesser splanchnic. So there are sensory fibers ascending up via the lesser splanchnic and enter T10. The problem is that when we study the anatomy at T10 level or any other level, right? This is T10 level. And this is the sensory fibers coming from the appendix, suppose. And the synapse at second order neuron here, sensory neuron in the dorsal horn of the spinal cord. But also somatic fibers come into the same place and synapse at the same neuron. So it means the second order neuron in the dorsal horn of the spinal cord could be activated by both visceral afferents and somatic afferents. The brain is accustomed to receiving sensation from somatic structures like skin, muscle, joint, somatic structures. We do not get appendicitis every day. So the brain is already accommodated or accustomed to this fact. So when we have appendicitis and the visceral fibers is activated, right? That's before the inflammation reaches the sensitive parietal peritoneum. It will activate the same second order neuron and the brain will project this sensation to T10 dermatome, which is around the umbilicus. That's why patients with appendicitis, they present with periumbilical pain. That's the mechanism. Okay? But later on, when the inflammatory process reaches the sensitive anterior parietal peritoneum and activate the somatic fibers in that peritoneum, the pain becomes localized to the right iliac fossa, sharp localized pain, leading to shifting pain. Okay, that's the mechanism. They love this in the exam so much. It can come in any form, okay? Okay, so we talked about thoracic splanchnic nerves. Now, I want to talk about a different type of splanchnic nerves, which are called lumbar splanchnic nerves, okay? Now, moving on to the lumbar splanchnic nerves. We talked about thoracic splanchnic nerves, now we talk about lumbar splanchnic nerves. The lumbar splanchnic nerves are 2 to 4 in number, they are variable. They originate from the lower, as the name implies, lumbar spinal cord. So if we take a cross section at the level of L1, L2 and below, this is L1, L2 and L3 and so on. From L1 and L2, the preganglionic neurons will emerge. That's at level of L1 and level of L2. Sometimes there is contribution from L3 as well, but generally speaking, the sympathetic system is a thoracolumbar outflow involving all the thoracic spinal cord and L1 and L2 only, okay? Then they will come out as preganglionic nerves, but here they actually synapse at the sympathetic chain, unlike the thoracic splanchnic, which are preganglionic. Now here, the preganglionic fiber exit and immediately synapse with the postganglionic. It relays here, right? Postganglionic fiber. The postganglionic fibers, they leave and enter the plexus of nerves located anterior or anterolateral to the aorta, right? Which is called the prevertebral plexus. I will come to that later, but that's aorta. This is celiac trunk, superior mesenteric, inferior mesenteric, and that's the bifurcation of aorta, right? These fibers will reach this region and join the plexus of many nerves, right? Intermingled with each other over here, called prevertebral plexus, which is autonomic nerve plexus. In the end, I will tell you about it, because each of the nerves that we speak about have a contribution to this plexus. One of the contributors to this plexus are the lumbar splanchnic nerves, okay? So those are lumbar splanchnic nerves, which are postganglionic sympathetic fibers, originally coming from L1, L2. Then they will just simply travel with the branches of the inferior mesenteric artery, okay? Some of the fibers will pass with the inferior mesenteric artery to supply the hindgut with sympathetic fibers. Right? This includes the distal third of the transverse colon, descending colon, sigmoid, and parts of the rectum, right? That's one part of the lumbar splanchnic nerves. Some other fibers, they actually go down to the pelvis, right? They go down to the pelvis, and there in the pelvis, they are distributed, right, to supply pelvic organs. Right, pelvic organs such as prostate, right, such as rectum, such as seminal vesicles, such as urinary bladder, and also the erectile tissues of the penis. Now, it is time to talk about the pre-aortic plexus, guys. It's time to speak about the pre-aortic plexus. What is pre-aortic plexus? It is just a group of nerves located in relation with the abdominal aorta, right? That's abdominal aorta and its bifurcation site at L4. Again, celiac artery, superior mesenteric and inferior mesenteric. This plexus of nerves, they extend from the origin of the celiac artery and they descend anterolateral. They are kind of hugging the aorta, and they eventually go down below the aortic bifurcation level and then split into two nerve bundles that will enter the pelvis. Okay, so suppose we create this opening as the pelvic inlet. Okay, so they enter the pelvis, and we will talk about what happens to them in the pelvis. Okay, but as a general scheme, this plexus as a whole, from up to bottom, is called prevertebral plexus. It has some subdivisions, this prevertebral plexus. The part of the plexus which is around the celiac artery, this part of the plexus, around the celiac artery and the superior mesenteric artery, is called celiac plexus, is referred to as celiac plexus. And inferior to that, and until the bifurcation of the aorta, it's called aortic plexus. Below that, below the aortic bifurcation, this part of the plexus is called superior hypogastric plexus. Superior hypogastric plexus. Is that okay? Now, the superior hypogastric plexus ends by dividing into two nerve bundles referred to as hypogastric nerves. These nerve bundles are called hypogastric nerves. Hypogastric nerves. Okay, guys? Now, I will be drawing the sacrum, the sacral foramina over here. There are 4 sacral foramina, right? 4 pairs. From S2 and S3 and S4 spinal nerve fibers, there are parasympathetic fibers which will come out. Parasympathetic fibers which will come out, and these parasympathetic fibers are called pelvic splanchnic nerves. Pelvic splanchnic nerves. We will talk about them in details in pelvis, but simply I'm going to give you the high yield points about them. Number 1, they are parasympathetic fibers. Number 2, they originate from S2, S3, and S4. Number 3, they join the hypogastric nerves. And together they make up another plexus called inferior hypogastric plexus. This one inside the pelvis is called inferior hypogastric plexus, a very important plexus in exam. Right? So inferior hypogastric plexus is formed when the hypogastric nerves from the superior hypogastric plexus join the pelvic splanchnic nerves from S2, S3, S4. Now how this entire thing from up to down, this entire plexuses is called prevertebral plexus. Prevertebral plexus. So this prevertebral plexus is simply group of autonomic nerve fibers, afferent and efferent, extending from just below the aortic hiatus of the diaphragm down to the pelvis. All of that is called prevertebral plexus, and it is divided into subsidiary plexuses, including celiac, aortic, superior hypogastric, and inferior hypogastric. So how this plexus is formed? It's simply contributions from the nerves that we talked about, right? So we have the greater, lesser, and least splanchnic nerves moving inside. Again, let's revise. Greater synapse at the celiac ganglion, at the celiac plexus, lesser synapse at superior mesenteric or aortico-renal, and least move into the renal plexus. In addition to lumbar splanchnic nerves, which are 2 to 4 nerves. Lumbar splanchnic nerves, which are post-ganglionic, remember that, so we're going to draw them like this, from L2 and L1, and they also come in to be distributed into the hindgut, as we said, and down below they go. That's very important. These post-ganglionic sympathetic fibers, some of them come down to the superior hypogastric plexus, and then from there through the hypogastric nerves to come down to the inferior hypogastric plexus. So these are feeding in sympathetic nerve, post-ganglionic sympathetic nerve fibers, which are feeding down to the inferior hypogastric plexus. And from that inferior hypogastric plexus, some of the fibers will go to the erectile, will go to some pelvic organs, such as prostate, right? Such as the seminal vesicles behind the urinary bladder and in front of the rectum, such as the vas deferens and the epididymis, right? And the other pelvic organs, like urinary bladder, rectum, vagina, and the female's uterus. So the thing is that something they love in the exam so much, which is about ejaculation, ejaculatory reflex. Ejaculation reflex is sympathetic reflex, right? What happens? Simply that from L1, L2 levels, when ejaculation reflex is activated, L1, L2 levels fire. When they fire, the impulse travels through the lumbar splanchnic nerves and then move to the prevertebral plexus, descend down and through the hypogastric nerves to the inferior hypogastric plexus, and from there to the organs which initiate the ejaculation. They cause contraction of the prostate and squeeze prostatic fluid, contraction of seminal vesicles and squeeze that, contraction of vas and squeeze the fluids in the vas, and ejaculation happens. So how can they ask you about this in the exam? One common way to ask about it is someone with a prostatic malignancy. Let's say someone with, more common example, testicular malignancy that has spread to the lumbar lymph nodes, right? And we did retroperitoneal lymph node dissection, and unfortunately post-operatively the patient complains of failure of ejaculation. What is the structure that is damaged? Of course, obviously lumbar splanchnic nerves, right? Lumbar splanchnic nerves have been damaged during the operation, which was carrying the impulse for ejaculation, right? Another thing, someone is doing some kind of pelvic operation. After the operation, they have failed to achieve an ejaculatory reflex. Which of the following structures is damaged? Hypogastric nerves. Those were feeding in those sympathetic fibers originally coming from lumbar splanchnic, right? So remember, hypogastric nerves, lumbar splanchnic nerves, those are nerves in the pathway of ejaculation. In the pathway of ejaculation. So that's how the prevertebral plexus is formed. Contribution from multiple splanchnic nerves. The inferior hypogastric plexus, as I told you, receives contribution from pelvic splanchnic nerves. There are other nerves called sacral splanchnic nerves. We are going to talk about them in the pelvis. There are also sympathetic nerves, postganglionic sympathetic nerve fibers. Or, let's talk about them right now. Simply what's happening. This is spinal cord at level L1, L2. Some fibers coming from L1 and L2, they come out, and instead of synapsing at the sympathetic ganglia at that level, they just don't. They just move down without synapsing with the postganglionic neuron and descend down to the sacral ganglia in the sacrum. So I'm going to draw here, sacrum. And these are sacral foramina, right? And these are the sacral ganglia, sacral sympathetic ganglia over here. They reach and synapse here at the sacral sympathetic ganglia. And from the sacral sympathetic ganglia, the postganglionic nerve emerge out and is contributing to the inferior hypogastric plexus as well. So here are the sympathetic ganglia here, and the postganglionic fibers emerge and enter the inferior hypogastric plexus. That's a they give minor contribution to the innervation of pelvic organs, sympathetic innervation of pelvic organs, but originally they are coming from L1 and L2, similar to hypogastric nerves. So this is all about the extrinsic sympathetic innervation of the pelvic and abdominal organs. Let's recap what we learned, the high yield points that I want you to know about this lecture. We said that there are thoracic splanchnic and lumbar splanchnic and sacral splanchnic. These are all sympathetic. The thoracic splanchnic nerves are greater, lesser, and least. Greater, lesser, and least are all preganglionic. All preganglionic. They don't synapse at the sympathetic chain. Greater come from T5 to T9. Lesser from T9, 10 or 10 and 11. Least from T12. Greater thoracic splanchnic, lesser and least, they enter the abdomen from the thorax by piercing the crura of the diaphragm. Greater synapse at celiac ganglion and supply for gut structures. Lesser synapse at aorticorenal or superior mesenteric ganglion and supply mid-gut structure. Least supplies renal plexus, kidney, and ureter, but not the adrenal medulla. Adrenal medulla is by greater. Then we talked about lumbar splanchnic nerves. We said there are 2 to 4 in number. They originate from L1, L2. They synapse there, and they are postganglionic. They are postganglionic fibers, not pre. What do they supply? Some fibers pass and supply hindgut. Some fibers descend in the hypogastric nerves to the pelvis and supply organs in the pelvis, right? Like urinary bladder, and there, if it's stimulated, what function will be there? Retention, urine retention, because it relaxes the bladder and contracts the sphincter. If it supplies organs such as prostate, seminal vesicles, ejaculatory duct, and vas deferens, it mediates ejaculation reflex. And then we spoke about sacral splanchnic nerves. They are also from L1, L2, but they descend down the sympathetic chain to reach the sacral ganglia and synapse there. Then postganglionic fibers emerge out as sacral splanchnic nerves and contribute to the pelvic organ sympathetic innervation. Okay, that's all that you need to know about the sympathetic innervation of the gastrointestinal and pelvic organs. Next, we move to the parasympathetic innervation of the gastrointestinal tract, right? So what happens is that we're going to take a look at the diaphragm from below. So for orientation, we will draw, this is T12, and after that is L1. Then we have L2, vertebral bodies, and we need L3 as well in the picture, so that's T12, L1, L2, and L3. Now, the thing is that the diaphragm, it has one of its posterior attachments is the right and left crura of the diaphragm. The right crus of the diaphragm originate as low as L3, so it attaches down to L3, right, and moves upward, also attaching to L2 and also L1 before moving up, right, and meeting the left crus of the diaphragm, which is usually from L2, a little bit higher, and then they meet each other here, right, and form a ligament called median aricoid ligament, right? We already know that. However, the right crus of the diaphragm has a superior muscular extension. Okay, it has a superior muscular extension called the muscular part of the right crus. This is referred to as muscular part of the right crus of the diaphragm, moving like it's muscle part, this one. Now, this is located at the level of T10, where the esophagus, right, emerges out into the abdomen and enters the abdomen, right? It attaches to the stomach specifically at the level of T11, okay? So that's the esophagus entering over here. Okay, here we have the abdominal part of the esophagus entering here. If we continue with the esophagus in the chests, right? So suppose we draw the rest of the esophagus here into the chests. If you remember from the thorax anatomy, the right and left vagus nerves were moving on each side of the esophagus, right? We have the left vagus nerve here and the right vagus nerve over here. You know, during embryology, the foregut rotates such as that the left vagus nerve moves anteriorly and becomes the anterior vagal trunk, and the right vagus nerve moves posteriorly and becomes the posterior vagal trunk, moving behind the esophagus and stomach. So the left one becomes anterior and the right one becomes posterior. Clear up to this point? Okay. Now, this diagram just shows us the entry of the vagus nerves into the abdomen. We just need to know they enter through the muscular part of the right crus of the diaphragm at T10 level along with the esophagus, such as that the left vagus nerve forms the anterior vagal trunk and the right vagus nerve forms the posterior vagal trunk. That's how they enter into the abdomen. Now we need to move to a different diagram so that I show you what happens and what are the branches, major branches that are given off each trunk. So this is the abdominal esophagus. Here it meets the stomach at the gastroesophageal junction. For context, this is the incisora. It becomes important just in a moment, okay? Which is this angle located along the lesser curvature of the stomach. Okay, now let's first talk about the anterior vagal trunk. Okay, that's anterior vagal trunk, which was coming from left. It is located, it moves in the lesser, along the lesser curvature of the stomach, in between the layers of the lesser omentum. Okay, it moves like this and it ends at the pylorus. What things that it gives? The major branch here, it will give hepatic branch proximally, or hepatobiliary branch. This hepatic branch moves and supplies the liver, the gallbladder, and also the biliary tree. Okay, that's called what? Hepatic branch. Hepatic branch. It will supply these structures. The continuation of the anterior vagal nerve just past this point where it has given the hepatic branch, we call it anterior nerve of Latarjet. We call this anterior nerve of Latarjet, or simply nerve of Latarjet, okay, or anterior, because there's a posterior nerve of Latarjet as well. From that anterior nerve of Latarjet, several gastric branches will move out and supply the stomach. It's going to supply the stomach. Near this point, near the point of the incisora angularis, or the angular incisor of the lesser curvature, it will break. It will break into multiple filaments. The anterior nerve of Latarjet breaks into multiple filaments which will enter the pyloric antrum and the pylorus. Right? That's the pyloric antrum, and this is the pyloric sphincter. Now this is a very essential nerve because it was used to be important in an operation called vagotomy. I will tell you about it in a moment. But that's what, this is pylorus, okay? And as I told you, the nerve of Latarjet moves and breaks near the incisora angularis into multiple filamentous structures. They resemble crow's foot, the bird, right? So they call this crow's foot. Crow's foot. Or some people call it pes anserinus. Pes anserinus. Is that okay? Now, why this is very important for us? The function of this crow's foot is that it supplies the pyloric antrum and the pylorus. And what does it do? You know, it coordinates a very important dance. There is a very important dance that happens. This dance is what? When food enters the stomach and the stomach starts the process of digestion, when the stomach wants to feed its content into the small bowel, what does it do? It coordinates a contraction when the antrum contracts and the pylorus relaxes a little bit so that it pushes some food into the small bowel. This dance is important for gastric emptying, that the pylorus has to coordinate contraction, relaxation, and the antrum has to contract to squeeze the food through the pyloric orifice of the stomach. Okay? So it means that there used to be an operation for peptic ulcer disease. That was before the era of proton pump inhibitors. This is called vagotomy. There are multiple variations of this operation, such as truncal vagotomy, where the main trunks of the right and left vagus nerves are divided, and selective and highly selective vagotomy. In highly selective vagotomy, individual branches from the vagus nerve are cut off. But the crow's foot and the nerve of Latarjet are preserved. Because if you know vagus nerve, it releases acetylcholine in the stomach and stimulate acid production in the stomach. So the idea is that if we cut vagus nerve, we reduce acetylcholine produced, and thus acid produced will reduce. and therefore the peptic ulcer will heal. That's the idea behind the operation. But they noted a problem that when they cut the vagus nerve from the top part, there is truncal vagotomy, not only acid secretion is reduced, but also the dance is abolished. The dance between the antrum and the pylorus no longer takes place. So it means the pylorus does not contract, the antrum does not contract, and the pylorus here does not relax. So food doesn't get to the small bowel. So that's called delayed gastric emptying. It was a common complication of these early operations. So it's called delayed gastric emptying. It used to cause a very big problems such as bloating and secondary gastroesophageal reflux. So what they did a modification to that operation in which they did what's called highly selective vagotomy. Okay? In which they remove these individual branches, they cut them off here, 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 with then preserving the crow's foot, preserving the dance. Here we will abolish acid, but the dance will continue. The pyloric antrum will contract and pylorus relax, so food is delivered. Another solution was given that this operation, highly selective vagotomy, is highly demanding. It needs some very good surgeon, and it needs more time. It's more complicated compared to truncal vagotomy. Truncal vagotomy, just go here and cut. So they did another situation in which they cut the trunk, right, of the vagus nerve, but they come to the pylorus and divide it partially here. They do what's so-called pyloroplasty, in which the pylorus, that's the pylorus, right? The pylorus is divided along the long axis like this. So you create incision like this, and then sutured along this axis to widen it and render it ineffective. So emptying continues, you get me? Anyway, so this is all about what you need to know about the anterior vagal trunk, right? It gives hepatic branch supplying, or hepatobiliary branch that supplies the liver and gallbladder and the biliary tree. It gives several gastric branches that move anterior to the stomach, and the nerve of Latarjet continues, and it ends at the incisora as a crow's foot, right? Breaking into multiple nerve filaments that supply the pylorus and the pyloric antrum. Okay, that's all what we need to know about this nerve. So let us move to a different diagram and talk about now the posterior nerve. What does it do and what does it give exactly? Okay, so that's again esophagus. Let's move a little bit here. This is esophagus. That's our beautiful stomach, our beautiful incisora. Now let's talk about the posterior vagal nerve, okay? I'm gonna draw it behind the stomach in a dashed line, so you know that it is behind the stomach. So, what does it do? It moves behind the stomach in a similar fashion near the lesser curvature of the stomach. And at this point, it is going to give an early branch called celiac branch. The celiac branch, it goes to, when we remove the stomach, right, and see what's behind, to look at the aorta, and that's the celiac artery given off of the aorta, right? And we talked in previous lecture that there is the celiac plexus, which is a subdivision of the prevertebral plexus, right? Just a filament of nerves here, and some ganglia here and here and here, right? There is celiac ganglion, superior mesenteric ganglion, and aortorenal ganglion. These are sympathetic ganglia, as we discussed about the splanchnic nerves, right? And then it just moves, the plexus moves anterolateral to the aorta. Now this celiac branch is coming in here and just kinda merge with the rest of the plexus. And along the branches, right, along the arteries, that is celiac artery and superior mesenteric artery and their branches, the parasympathetic nerve fibers will get distributed to the small bowel and get distributed also to the cecum and appendix and ascending colon, right? That there is midgut. So the celiac branch is what supplies midgut. So that's a major branch. It comes from where? Celiac? Typically from posterior vagal trunk. And then it continues past this point as the posterior nerve of Latarjet, and similarly it will give different gastric branches, right, that supply the stomach itself, posterior surface of the stomach, okay? Alright, but it is not like the anterior nerve here that gives the crow's foot and is the main player behind the dance, okay? Behind the dance between the pyloric antrum and the pylorus. Okay, so what's the functional significance? It means that vagus nerve provide parasympathetic innervation to foregut and midgut structures. To foregut and midgut structures, including abdominal part of esophagus, stomach, liver, gallbladder, pancreas, small bowel, and proximal large bowel. Right? And physiologically, in the stomach, it will stimulate acid production, right? By increasing acetylcholine production. It will stimulate gastric emptying. In the small bowel, it will stimulate peristalsis, stimulate digestion and secretions, and increase the blood flow to the gastrointestinal tract. So it means it's the nerve of rest and digests. It's the nerve of rests and digests, right? It stimulates the digestion process. Unlike the sympathetic innervation, that was provided from the splanchnic nerves, that we said it just inhibits the motility, it inhibits gastric emptying, it inhibits acid secretion, right? Because sympathetic is something that you need when you are running away from a big black dog, or from a dinosaur if you have lived in that era, right? If you are running away from a dinosaur or from a very big dog, that's the dog that you're running from. Dog's smiley because he knows it's gonna get you. Doesn't look like a dog, more of like a rat or something, but just imagine it's a dog and it's running. It's no time for you to eat the piece of chicken. Right? You need to, everything is logical. If you think about it logically, it becomes very logical. Okay? Okay, guys. So we talked about vagus. You may be wondering right now, okay, if vagus nerve gives the parasympathetic innervation to foregut and midgut, then what gives the hindgut? The hindgut, does it have a parasympathetic innervation? Yes. If you guys remember, I told you that this is coccyx and this is our beloved sacrum. Yes, this is our beloved sacrum, and here's the coccyx again. And sacrum has sacral foramina, right? Here, one. Sacrum is just 5 fused sacral vertebrae, right? Fused together. And then they have these foramina where the nerve fibers emerge. Sacral nerve roots emerge from these anterior sacral foramina. Now, We have important, when we talk about sympathetic outflow from the CNS, we say it's thoracolumbar outflow because it flows from T1 to L2 level. But when we talk about parasympathetic outflow from the CNS, we say craniosacral outflow. Craniosacral, because it comes out from cranial nerves like oculomotor, like facial, like, we talked about it in head and neck. And from the sacrum, that is from top and bottom. From top and bottom. Top and tail. So parasympathetic is top and tail, but sympathetic is in the middle, right? Thoracolumbar. So there is some part of the parasympathetic system that emerges from the CNS through this region. Specifically from S2, gonna give it like different color better. From S2, from S3, and from S4, right? They come out like this. These preganglionic parasympathetic nerve fibers that are emerging from here are referred to, as I told you earlier, that they are called pelvic splanchnic nerves. Pelvic splanchnic nerves. Is that right? Pelvic, P for parasympathetic. Sacral splanchnic nerve, S for sympathetic, right? So that you don't confuse them. These pelvic splanchnic nerves, as I told you, they join what kind of situation? This is aorta, above, bifurcating, right? Into right and left common iliac arteries. And we said that there's a continuation from the prevertebral plexus down, becomes superior hypogastric plexus. Then these superior hypogastric plexus divide into two hypogastric nerves, right and left hypogastric nerves, right? And then these two hypogastric nerves join the pelvic splanchnic nerves to form yet another plexus inside of the pelvis, which is called inferior hypogastric plexus, right? Which is located posterolateral to the rectum. The rectum is over here, guys. Okay, rectum is over here. We're just gonna remove the rectum for now, but it's in here. Imagine that it's inside, and this plexus is coming out from behind it, posterolateral to the rectum, and on the sides of the prostate, right? Moving on the sides of the prostate. But anyway, these pelvic splanchnic nerves will give parasympathetic supply to all of the pelvic organs, urinary bladder, rectum, prostate, and also the erectile tissues of the penis, and that's what causes erection. So pelvic splanchnic nerves are the ones that mediate erection, and sympathetic nerves, ejaculation. There's a funny mnemonic in EMRCS, if you have came along that. It's say parasympathetic points, meaning for erection, and sympathetic shoots, SS, shoots, meaning ejaculation. But whatever, that's a nice way to remember it, but whatever. However, this information, everybody knows that. Everybody knows that pelvic splanchnic nerves mediate erection and gives parasympathetic supply to pelvic organs. But not everyone knows that some of these sneaky fibers, right, move up. They move up. They skip pelvis. They move up through the hypogastric nerves into the inferior hypogastric plexus. They keep moving until the origin of inferior mesenteric artery. Inferior mesenteric gives left colic and several sigmoidal vessels and also superior rectal. These sneaky parasympathetic fibers move along the branches of the inferior mesenteric artery in order to supply the hindgut structures, right? The hindgut, meaning distal to the proximal 2/3 of the transverse colon, meaning distal 1/3 of transverse colon, descending colon, sigmoid, and rectum are supplied by pelvic splanchnic nerves. Okay? So it means, if they ask you in the exam, hypogastric nerve contains what? Or hypogastric nerve contain all of the following except. What does it contain? Very simple. It contains sympathetic fibers. If you remember, lumbar splanchnic nerves which are post-ganglionic, have entered the prevertebral plexus, descended down through the hypogastric nerve to reach pelvis. So number one, they have descending post-ganglionic, descending post-ganglionic sympathetic fibers. That's number one. Number two, our friend here, ascending preganglionic parasympathetic fibers. Ascending preganglionic parasympathetic fibers. And finally, they contain visceral afferent fibers from the pelvic organs. Visceral afferent fibers which mediate pain. They are part of sympathetic afferent fibers, which are also ascending up from the pelvic organs toward the CNS again for visceral pain. Okay? So that's in case if they ask you. Now you know what they contain. Again, they contain descending postganglionic sympathetic fibers, ascending preganglionic parasympathetic fibers originating from pelvic splanchnic, and visceral afferent fibers for pain, part of sympathetic. So this is all what you need to know about the innervation of the gastrointestinal tract, autonomic innervation. I hope you've enjoyed the lecture. Please note the high yield points about this exam, about this lecture. Number one, preganglionic fibers are the splanchnic ones. When we talk about the sympathetic, thoracic splanchnic nerves, greater, lesser, and least, are preganglionic sympathetic. Lumbar splanchnic are postganglionic sympathetic. Remember that the hypogastric nerves, lumbar splanchnic nerves, are all involved in the pathway for ejaculation. If you remember, we start from L1, L2, go to prevertebral plexus, descend through hypogastric to the inferior hypogastric plexus, and then distribute to the organs that mediate ejaculation. Also remember that pelvic splanchnic nerves are parasympathetic, preganglionics, and they supply pelvic organs, everyone knows that, but they also supply hindgut. What about midgut and foregut? Vagus. Okay, these are the high yield points that you must know and take home from this lecture. Thank you so much everyone for watching, and see you in the next lecture. Best of luck, guys.